J. Balvenkat Subramanian, 2050 Smart Drugs and Personalized Anesthesia. Dr. J. Balvenkat Subramanian is a renowned anesthesiologist, currently serving as Senior Consultant and Academic Director of Anesthesia and Perioperative Care at Ganga Medical Center, Coimbatore. He's the President of the Indian Society of Anesthesiologists, 2024-25, and Secretary of World Federation of Societies of Anesthesiologists, 2024-26. A passionate teacher, he has delivered over 500 lectures, conducted more than 40 hands-on workshops, published extensively in peer-reviewed journals. Dr. Balvenkat's dedication to enhancing patient safety and perioperative care has earned him national and international recognition, making him a highly respected figure in the field of anesthesiology. A very warm welcome to you, sir.
Pranams to everyone. Respected chairpersons, the President and Secretary of the ISACON Karnataka State Chapter, Dr. Manjula and Dr. Njirappa, and the local team led by the organizing chair, Dr. Anand Bangera, Secretary, Dr. Sripada, the ISA Mangaluru City Branch President, Kishan Shetty, and Secretary, Dr. Meghna, and all the heads of the department of several medical colleges of this medical city, Mangalore, and delegates from various parts of the state of Karnataka. Good afternoon, everyone. And I know it's tough to give the last lecture of a CME, but I thank the organizing team for giving me a concept and a topic that's very intriguing, and how anesthesia would be probably in 2050. And we need to really see 25 years down the line, and now try to analyze what have we achieved in this 25 years between 2000 to 2025. Certain things have changed, certain things haven't changed at all. It depends upon the individual to embrace the new technique and the technology. With this introduction, I bring to you greetings from the city of Coimbatore, and currently the city is known for this mammoth structure, which is present in Isha Yoga Center. And the reason I project this is, if this becomes a part of everyone's life, yoga becomes a part of everyone's life, with the whole globally it is being embraced. And if it becomes part of every professional anesthesiologist, he will get enriched both spiritually, mentally, physically, and in decision making. And it makes them much vibrant than what they could ever be in their clinical life. And two slides which have become very prominently positioned in all my talks is because these two slides I revere most, and I think they've inspired me to generate the interest and passion within me. We may be born in a middle-class family, but we can scale such heights in this lifetime that we can cause a revolution. We may have been born to illiterate parents, but we can die as a scholar of world repute. We may have been considered a misfit during our childhood days, but we can become role models for the future generation. What we are and what we have been has no bearing on what we can be. We can choose. We can be what we choose to be is a very profound statement which holds good for every single anesthesiologist, whether they're a postgraduate or the head of the department. But to accomplish all this, it's important that we need to keep asking ourselves, my future comes from where my time goes, so where should my time go? For everything that you want to do, you need to have the time. In essence, we reach a point in life when time becomes the God. Again, I consider this such an important slide. On all those who have been successful, I think they have been successful because they have understood how to use that 24 hours that is present with them to grow. And this slide is another permanent slide because all of us want to be successful. And what does it mean? Success is all about being in the process of joyfully creating a life that reflects your highest values, your deepest beliefs, and your greatest dreams. And As the current president of Indian Society of Anaesthesiology, I will take this opportunity to share some of the thoughts that have emanated and what we tried to do this year in this country. Happy to share that we are 50,000 members now, and becoming one of the largest medical organizations anywhere in the world. Number two, we have become the fourth largest member society for the World Federation of Society of Anaesthesiologists, next only to US, China, Germany, and India. We moved from 12th position to this fourth position. And with this power, we are planning and we are going to bid for the World Congress of Anesthesia in 2030 in India. And I hope we will be able to achieve and accomplish this. I also considered it was very important for a professional organization to focus on the perioperative morbidity and mortality. And hence, before even I took up, we did a nationwide survey and found out the 6 common causes of perioperative morbidity which happens in our country. And thanks to all the simulation leads, about 40 of them from various parts of the country, who came together and created an ISA module of simulation-based learning, specially focused on this 6 case scenarios which resulted in morbidity and mortality, and trying to make sure that this reaches all those who have not been able to be a part of big corporate units, working in smaller cities, working in tribal areas, had probably not got an opportunity to update themselves. And this is exactly what we wanted to do in preserve every single preventable death in this country. And I thank ISACON Karnataka State Chapter for doing this ISA module simulation workshop yesterday in AJ Medical College. And thanks to Dr. Lulu Sharif and team for doing this so very well. And this has been our priority, and we conduct this program across the country, and we wanted to patent this and do this more in the ensuing months and then years to come. Then we thought it's very important to create visibility of the work done by Indian anesthesiologists to the world. And how do we do this? So we entered into a memorandum of understanding with American Society of Anesthesia, with European Society of Anesthesia and Intensive Care, American Society of Enhanced Recovery, the Patient Blood Management International based in Europe, and 6 more organizations across the world in terms of education, research, and advocacy. And I'm 100% sure this will result in exchanges between the nations, and they will start understanding the power of India and Indian anesthesiologists. And also we thought it's prudent and important to get all these specialty societies under one roof. So we, as an ISA national body, have signed a memorandum of understanding with 12 subspecialty societies, including IACTA, IAPA, ISANAC, AORA, AOA, and now we are getting all of them under one roof in the national conference at Raipur, and henceforth they will have their own sessions in the national conference so that we bring together people of experts from across different societies under one roof. And I'm also happy to share that wherever the World Federation wanted, we stepped in and we represented the World Federation of Society of Anesthesiologists in the World Health Summit held in Delhi. And I only wish that we continue our journey, and I take this opportunity to welcome you all to the next national conference, which is to be held from November 25th to 30th at Raipur. And I'm also happy to share that the entire World Federation board of WFSA board, which has got 7 of them, including the president of WFSA, will be in Raipur, and I would wanted all of you to come and network with them. I'm also happy to share that I utilized my current responsibility as the secretary of the World Federation of Society of Anesthesiologists to influence the board to move the board meeting. Normally, they have the board meeting along with the American Society of Anesthesia meeting. And this time I managed to shift it from there to get them to India. So the WFSA board will meet along with the Indian Society of Anesthesiology meeting. So we also have incorporated a lot of new things, including live workshops, leadership summit, then master classes, and I hope and I'm sure that as an academic body, we will be inferior to none globally. And a word about serving in the board of the World Federation of Society of Anesthesiologists. What is WFSA? It's the largest global networking of anesthesiologists, headquartered in London. The office has got 14 permanent secretaries, and currently we have 152 countries as members of the World Federation of Society of Anesthesiologists. And here, among these 152 countries, we have become the 4th largest country. And the WFSA, the vision is universal access to safe anesthesia, and the mission is to unite and empower anesthesiologists around the world to improve patient care. And to make this happen, normally, if you see the deprived geographies are Africa and Southeast Asia, and all the time, these countries were looking for help from United States, United Kingdom, and Europe. We wanted to change this, and we wanted to show to the world that Indian anesthesiology can do this, like what the developed nations have done to Africa and Southeast Asia. We made a beginning in that a delegation of 12 Indian anesthesiologists went to the capital of Tanzania, Dar es Salaam, and taught 80 out of the 120 anesthesiologists for 4 days and made a new impact in the world order that Indian anesthesiologists can deliver the goods and teach. And we focused on works like ultrasound-guided block, point-of-care ultrasound, cardiac anesthesia, pediatric anesthesia, high-risk obstetrics. And I'm extremely happy to share that this was extensively covered by the entire news of the Tanzanian television, the newspapers, and the Indian High Commissioner in Tanzania accorded a welcome reception, and this is going to be an annual event hereafter. And for the Pan-African Congress in 2027, they said all the workshops will be done by Indian anesthesiologists that will be held in Tanzania. So we wanted to make inroads and show the power of India to the world. I'm also happy to invite all of you to the next World Congress of Anesthesia that is to be held in the month of April in Marrakesh, Morocco. And this is something which I request the entire state of Karnataka to have a big delegation, not only to be a part of the Congress, but also to present your work at the international level, because they need to know the good work that's being done in this nation. And I welcome you all. The registration for this will start very soon. I bring to you greetings from Ganga Medical Center and Hospital, Coimbatore. It's a 650-bedded tertiary care referral center for trauma, orthopedics, major plastic reconstructive surgery. And I would welcome all of you to our center. Currently, we have 38 operating theaters, 94 anesthesiologists, about 150 surgeries per day, and 14 anesthesiologists on call in the night, including 3 consultants, to make sure that every trauma patient comes in the night gets the best. And also, we have removed all the physicians from the hospital. The last 2 decades, anesthesiologists have been serving as the perioperative physicians. So right from getting the point-of-care ultrasound to ward rounds, constipation or loose stools or electrolyte imbalance, everything is being done by the anesthesiologist, has enhanced the reputation of the fraternity of anesthesia inside the institution. And I'm sure this would be the answer that we give for the topic today on personalized anesthesia. I took the opportunity to explain more about ISA and WFSA because, as the chairperson said, one speaker did not come. And I thought it's important and prudent to make sure that all that we have been doing reaches to all the members who have been part of this journey of Indian Society of Anesthesia. When we look at what's going to happen in 2050, I think we need to see what has happened to this country in post-independence, and then we will get an answer on what we can offer to our patients. So ours is absolutely culturally diverse country, spiritually strong, extremely populous, bestowed with the best of natural resources, the best of man-made resources. But still, when we got independence, this was the heart of the commercial capital of India, Mumbai, and majority of the people were traveling like this. I'm giving this as an anecdote of what can happen in 25 years. So what has happened to us now? So we have the second largest highway network in the world. We have one of the largest sea link in the world. Our downtowns, many downtowns have started looking like this. This is not Chicago, this is India. And we put Chandrayaan on the moon. And why was this possible? This was possible because this nation thought they can adopt the new technology. This is exactly what we need to do as an anesthesiologist to push ourselves to the modern technology. And this topic of smart drugs and personalized anesthesia is probably looking at what we do. The way we giving anesthesia has completely changed. When I started giving anesthesia for our scoliosis surgery, I looked 25 years back. All scoliosis surgery, we are a center for scoliosis, so we operate close to 8 to 10 scoliosis per week. And we get referrals from across the country and outside the country. So initially, we were doing it with inhalational agents, muscle relaxant, then we used Stagnara wake-up test, and prolong the duration of anesthesia. Sometimes the patient takes a long time to wake up. So this was exactly what was happening in 2000. And where are we in 2025? Phenomenal change. What was the reason for this change? That was because of adoption of new technology. What new technology was adopted in scoliosis? Number one, all these patients switched from inhalational anesthetic agents to intravenous anesthetic agent. Target-controlled infusion is the norm now in all scoliosis surgery. No muscle relaxants, continuous monitoring of MEP and SSCP, continuous BIS monitoring, and making sure that you use the new devices which have come in. And we are extremely fortunate that all these devices are available in this country. And now I would wanted to ask a question. How many of you here use TCI in your clinical practice? Please raise your hands. I'm very happy. Few hands have gone up, but a lot more hands have to go up. And with the advent of TCI, Shivkumar is here, who is a strong proponent of TCI and formed the TCI Association for this nation. I'm very happy that with the advent of remifentanil, propofol, and dexmedetomidine, you can do wonders with TCI. So there is a marked difference between what we did with inhalational to what we are doing with intravenous agent, which is purely based on the pharmacokinetic model. This is the progress. This is the smart way. This is the smart drug. This is the smart technology. But the most important thing is you have to adopt it. You have to use it. You have to clinically see that it helps you. And now with the advent of remifentanil, so for scoliosis surgery, it is remifentanil, dexmedetomidine, propofol, and thanks to the advent of regional anesthesia, all these patients get a 4-quadrant erector spinae block. So a 4-quadrant erector spinae block, which is ultrasound guided with a TCI, and you extubate a 6 hours, 8 hours surgery on table and child smiling. So this is the progress that we have made between 2000 and 2025. Now I extrapolate what would happen from 2025 to 2050. Now, majority of the institutions which have gone into research, at least 6 of them I know, have started doing pharmacogenetic studies of though patients who are coming for anesthesia as a pre-anesthetic checkup. They take a buccal smear, and this is sent for the genetic sequencing. And what it really finds out is, it finds out primarily on the current research, which has been proven research, is cytochrome 450, the phase 1 the way the phase 1 metabolism happens for the drugs. So there are different kinds based on the genetic parameters, the way they will metabolize a particular drug. So now it is done. Now we find out and categorize them into which group they belong to. And based on that, the perioperative anesthetic and analgesic regimen are scheduled. This is a major progress that has happened and will happen and will dictate what we are going to do. This is phenomenal, a radical change in our thought process. Because many times for the same kind of anesthesia that you give, we have seen that you do an ACL reconstruction, arthroscopic reconstruction of the knee joint, for example. 40 years old, 2 women operated on the same day, same multimodal analgesia. One is extremely comfortable. The other one is continuously complaining of discomfort and pain. As a young anesthesiologist, I always used to think that this was an emotional component and an overreaction of the patient. But now I realize that the one who responded is the one whose cytochrome 450 is completely different from the one who didn't. So there is a complete change. So all that we did not know, now when we start knowing, we will start blaming the patient and we will start knowing the reality that is happening. So this is what is happening genetically. And now, what else is going to happen? I'm giving a 4-quadrant, now I'm giving a 4-quadrant erector spinae block. There is a possibility from the way we have grown and progressed. I'm not sure how many of you have read this new development, neuromodulation to decrease acute pain. So no local anesthetic is needed at all, no smart drug. It is the endogenous release of substances secondary to stimulation of the neural tissue as an answer to your acute pain, which started with chronic pain and now it's moving on to acute pain. When I went to US recently, I saw a new device. Suppose you undergo a total knee replacement. Instead of giving the femoral block, which actually produces motor power, which is lost, so patient cannot move. And many surgeons wanted the patient to walk on the same day after a TKR. Now the new neuromodulation is this device that you keep transcutaneously over the femoral nerve. It delivers a current to the femoral nerve, stimulates the femoral nerve, and makes sure that it produces the analgesia that is needed. So this is a remarkable change that has happened in the way pain would be treated. So possibly we would reach a stage where local anesthetic solutions will be used very sparsely and most of the analgesic component will be done by neuromodulation. It's absolutely exciting. And also it is exciting that if you see conscious sedation, we went into a lot of conscious sedation when we do patients under regional and ultrasound-guided blocks as well as neuraxial blocks, and especially in pediatrics. Now, with the development of technology, the virtual reality has come inside, and I'm not sure how many of you use music therapy and virtual reality in pediatric practice, but it's come a big way. I've seen studies being done in a young pediatric patient, done under regional, no conscious sedation. They are just glued to the game that they used to play at home. So that's put on the patient, and the patient is continuously engaged in that, and no drugs have been given. So this is coming in a very, very big way, and many publications have started coming in which would decrease the use of this drug. So these are absolute exciting factors where we are moving towards, and now we have ultrasound machines which have got such high frequencies that you can see the nerve, like superficial nerve, so very well. And you can put microcatheters into the nerve. Microcatheters into the nerve. So the nerve has got a covering. You have the epineurium, the perineurium, and then you have the fascicles. So you put a small microcatheter between the fascicles, and then you put a continuous infusion. Seems to be remarkable in the way we have changed. So the technology advancement has become so phenomenal that if it is incorporated into our day-to-day practice, 25 years from now, all that anesthesia that we are going to deliver are going to be completely different. But the question is, how many people will adopt it? In India, adoption is the most important challenge. And I would visualize that with the growing, the corporate units coming in across the country, excellent medical colleges like what you see in Mangaluru coming into the country with very good infrastructure. I've never imagined that a medical college can have a convention center like this 15 years or 20 years ago. So this development is clear indication that adoption of new technology and technique would become an inherent component, and India will progress as much as any other country in advancement of using this new technique and technology into clinical practice. So it's very important we need to change. That's exactly the adoption. It's not the strongest of the species that survive, not the most intelligent, but the one most responsive to change. And I think we need to change for good in adopting this modern technique and technology, and then we'll move towards excellence. Excellence is never an accident. Masters make everything look so simple. The most brilliant of the best do their craft with effortless ease and exceptional grace, or at least make it look the way to you and me. This is what exactly happens when we do a scoliosis surgery now, that it's such amazing to see the child getting up, smiling with no pain. And this is because of the adoption of technology. And if you want a personalized care, I think it's truly very, very vital that you become a perioperative physician. So we have been compared to a pilot, but we need to be compared to a tailor henceforth. That is called as personalized anesthesia. So where that we go to the tailor because you want them to stitch exactly according to the measurements that we want. Same thing is for anesthesiologist, that an anesthesiologist has to tailor make the anesthesia regimen that this particular patient needs, and that is procedure specific, patient centric anesthesia has to be given. And what do you mean by this? I will give another example. Every surgical procedure, when you write the postoperative pain, we all write one paracetamol, one non-steroidal, and maybe an opioid. But over a period of time, it will become a mathematical calculation. What was the surgery? What was the incision? What was the myotomal injury? What was the dermatomal injury? What was the osteotomal injury? So you will calculate. You will put, these are the myotomes involved, these are the osteotome involved, these are the dermatome involved. So now you will block the nerve, all the nerves which produced the nerve supply to dermatome, myotome, and osteotome. Absolutely scientific, specific, and that's number one. Then number two, you will see whether it's only a somatic pain or a somatic pain with visceral pain, or somatic plus visceral plus neurogenic. Then now, based on this, you will decide what you will give for all these things. Now it has also been understood that when a major surgical surgery happens, there is a surge of pro-inflammatory cytokines within the body, the IL-6. Many centers have started measuring interleukin-6 level as a component of pro-inflammatory substances which are released after a major surgery. And these substances go and work on the nociceptors, which are present in where the tissue injury is, to enhance the pain. And now different substances have been identified to make sure that these nociceptors are blocked. Advanced research is happening in making sure that the new nociceptors, where they're concentrated, how to make sure that we down-regulate their activity. And also now, measures are on to increase the substances that are given inside, which pharmacologically stimulates anti-inflammatory cytokines within the body, the IL-10. So when the IL-10 levels start going high immediately after the tissue injury, when it goes more than the IL-6, the patient's analgesic requirement becomes very less. So we are going towards exciting times of even smallest thing that happen, which will make sure that we move towards personalized care. And for that, I think the starting point is we become perioperative physician, and we can go in delivering absolute quality anesthesia to our patients. Quality has been defined by 6 domains, being very effective, equitable, timely, efficient, safe, and patient-centered. So I look forward for that day when, as an anesthesiologist, you see the patient, he comes to the pre-anesthetic room. In 2050, when all of you are practicing, I'm sure everybody will be practicing, because now the average age of Indians who lead a good life, 90 and 100 is common. Before last week, we operated a patient who was 112 years, who came for hip fracture. And he could see well, he could hear you well, he could make a joke, he could understand it so well, discharged on the 4th day. So it means that Indians and India will see 110 and 120s maybe. So 25 years down the line, when you start practicing, I visualize in the pre-anesthetic room, patient comes in, you get the history, you take a smear, send it for genetic study, and that genetic study will map what kind of cytochrome he has, and it will give the medications that have to be given for this patient, how he will be receptive. Then you will take the ultrasound, put it here to see how the airway looks, what is the subglottic area, so which endotracheal tube that you will be possibly using. Then you will just put it on the lung to see, because you saw the saturation, it was 94, and you will see whether both the side lungs are okay. Then you will just put it on the heart, and you will see the pumping is okay, there are no regional wall motion abnormalities. And when the patient comes to the OT, you will put it on the stomach to see what has been the volume, gastric volume inside. And you will get into a workstation where will you enter all the patient details. You will switch a button, TIVA TCI, and set the drugs in, and everything will be monitored, and you will put your near-infrared spectroscopy, which will see the tissue oxygenation, and it will be a servo. It will go back to the workstation and deliver more oxygen, and your job will become very, very simple. It's just that you need to know that these technologies have come in. You need to adopt this technology, and it would become so difficult that you will not find a reason to have a morbidity and mortality. And also with the new learning curve that is coming up, when you sit in the car, whether you're in Chicago or whether you're in Tokyo, if you know to drive a car, all that you do is GPS. And this is what will happen, and this has already happened. For all those who are doing ultrasound-guided block, now the new machines, all that you have to put is femoral nerve block and put the probe and put the needle, and it will command, go lateral, go medial, go 1 centimeter below, 1 centimeter lateral. So it will give you the direction, and you will reach and do an excellent block. The surgeon will think you're excellent, but he doesn't know that you're using a GPS in your ultrasound machine. But it is exciting times ahead. And it is important that each one of us embrace these new technology, incorporate that into our clinical practice, and make sure that we offer the best to the patient. I will end by saying we do a lot of fellowship programs, and recently we received an application, and he was 72 years old. So I took the phone number and I called him. He's from Thane, Mumbai. I said, sir, you have applied for 6 months fellowship in regional anesthesia in Ganga Hospital. We have put a column in our website that it is for those below the age of 40 years. So he said, I know, I saw that, but I still wanted to apply because before I die, I want to do one block of brachial plexus, and I don't want to give any sedation, and I want the surgery to be done only under the block. This is my vision, and before I die, I want to do this. Even if you don't take me for a fellowship, please give me an opportunity to come and work and make me do one block, so when I die, I will die so peacefully. That was the kind of urge that he had in adopting the new technology, and I think each one of us should embark onto this journey of incorporating the new technology and giving the best to our patients so that we make sure that we preserve every single life that comes for surgery, irrespective of the comorbidities and the age of the patient. 2050 looks exciting. Let us be part of this journey of creating history. Thank you so much for your patient hearing. Any questions?
Here also, we actually involve our juniors whenever we find it difficult to give some blocks. We never hesitate. We call them and give the best care to our patients. Many times your own students have helped us in giving the blocks. So that way we also do it, sir. Even though we are not able to give on our own with the ultrasound guided, but we make the patient very comfortable.
Absolutely,
These
sir.
days. One more doubt is there any development recently on understanding how much pain patient may suffer during anesthesia and post-operatively? Is there any monitor developing, or is there any chance of such things coming in the future?
Yeah, sir, I think a lot of research has happened into this because this is one which we have not been able to conquer. There are several things already published. The basic thing is the algometer, which is used to assess the pain. But there are, in literature, there are phenomenal amount of both biochemically and otherwise. Based on the pupillary diameter, now they've started analyzing the intensity of pain. And instead of, because what we do, VAS score is very subjective. So we wanted something objective to measure pain, and that's why first algometer came in. And now the new investigations are going on the pupillary diameter in relationship to the pain. But biochemically, there are a lot of investigations that are happening in getting the pro-inflammatory substances which get released after tissue injury, based on that level to enhance the medications that you would give. And as I said, this is combined with the pharmacogenetic parameters, which shows that whether they are a slow metabolizer, mediocre, middle metabolizer, or fast metabolizers. Based on that, the drug dosing is changed and the frequency of giving the drug has changed. But absolute exciting field is pain. And I'm sure in 2050, there will be a lot of answers to this question.
Sir, one question. Nowadays, the science and technology developing so fast. So, at a future date, do you see the role of human doctors are no more needed, and it's fully taken over by machines?
Sir, it can never happen. It can never happen. I think we need not be afraid. All of us are afraid of the head of the department, and we wanted the head of the department to retire fast, because we need to become the head of the department. So similarly, now there is a new competition, whether once the machine comes, whether I will go out of practice, and whether a robo will sit in the head of the department office to do this. It's a very wishful thinking that this competition between man and machine is going to happen. In fact, I was in Dubai for the Pan-Arab conference last month, and they have a new building, which is phenomenal. I think even our country has to move towards that. We are, but because I think the funding is good. And the receptionist there in this new building was a robo. So the robo only welcomed you, and the robo asked which department you want to go, and this was phenomenal. So asking your question, there can be robotic anesthesiologists available inside the theater. So this is definite possibility. I'm not scaring, but this is definite possibility because the technology is moving towards that. But however, I am 100% convinced that this side it can develop, but on the patient side, the robo can never give that emotional touch, will never tell the patient, do not worry, I will be with you, I will take care of you, and remarkably assist them emotionally, which none of the machines will be able to do it as of now based on the technology. I think maybe 50 years down the line, even the robots can cry, even the robots can smile, you never know. But until then, I think we have a possibility that human touch would always be there and decision makings will still be with the human anesthesiologist. However, they can perform extremely well when they adopt this technology for best outcomes.
Thank you, Bala sir, for this exciting.
And also there is another advantage. Probably 2050, we can also have, if the hall is less crowded, we can put robots inside.
Very true, sir. Thank you, Bala sir, for this exciting lecture. We always look forward for your lectures. As Abraham sir told, with the advancing AI, lot of things are in different perspective. As you said, the ultrasound guidance itself may guide us to the nerve sheath where we are supposed to deposit the local anesthetics. Is it possible to have a device like Kepler, which was the initial device for intubation? Or similarly, we can have a device to achieve epidural anesthesia. But the human anatomy is known to be vastly variable. Though the machines can learn very fast, the variations are always there. And the other side, human errors cannot be eliminated. Not possible, whatever said and done. So in this conflict, how much are we going to adopt the technology, especially the robots? Like now, for every other surgery, we have robotics, say knee replacement or even abdominal surgeries, even neurosurgeries. How much more machines are going to intervene between the patient and anesthesiologist?
It's going to increase because now advanced research is happening in airway robo. So difficult airway hereafter will find a lot of solution because it is going to reach angles which a human hand cannot reach. Where you wanted a fiber optic bronchoscope to go inside, but the new research of airway robotics, even in fact IIT Mumbai is doing an advanced research in airway robotics, looks very exciting. So what do they do? Because there is a lot of variability in human anatomy, serial MRI sections of the airway are done, few thousands, and the data is integrated and it is given to the robo, and then it devises a strategy to go and intubate looking at that particular angulation. So there will be a stage where fiber optic is not needed. You give it to airway robo and give the MRI picture of this one. It will calculate everything. It will go and intubate and come out. So this is definitely 100% this is going to happen. Advanced research is happening and already they found out a lot of solutions. And similarly, the robo has come for giving peripheral blocks. It's already proved. It's already in use in few institutions. All that you said is, I'm not sure you've seen the Magellan robo for peripheral nerve blocks. So, sir, please employ still our alumni, the regional anesthesia. Don't involve Magellan robos because now they're available. All that you have to do is you have to earmark where they have to go and do the block. And the probe is kept, so it measures the depth, it will measure the angle, and the needle will go towards that, and the set target drug will be injected inside. So both this is possible, it's happening, it's already started, and I think, again, these are absolutely new frontiers, and in 2050, if it happens to be the state conference in Mangaluru, and we should reassess, revisit, and a lot of people will be using all this, and it's going to be absolutely, truly exciting. But both this are on, it's not even a dream, but it's already happening. Yes, Aisha. So I'm very happy to see Dr. Shilpa and yeah, currently working in Bangalore, Apollo, and thank you, Isha, for.
Yes, sir. My question is, with these advances that are happening in terms of technology, where do you see us as anesthesiologists teaching future anesthesiologists? How much more difficult is it going to be to teach our juniors what we have learned? Because we've had the advantage of learning from the greats like you and having hands-on experience. So with the rate and the pace at which everything is changing, how do you think it's going to impact teaching anesthesiology in the future, sir?
No, I think it will never change. So whatever I spoke is to show that so much is happening, but I don't visualize that they will replace it at any given point. And this teaching will go on. Only thing is it helps us to become more precise, and incorporating them into our clinical practice will make a critically ill patient to get the best understanding of things which we didn't understand to become better, but mentoring, teaching, precision, all will never change. 100% will never change. Only thing is it will make it difficult for us to lose a patient because of errors, which we do now. And I'm very confident that this revolution is more towards patient safety, and nothing else is going to change. You will continue to be an excellent teacher for your young children. And in 2050, when you're the head of the department of a unit, you will still have the same pride that most of the teachers have now. That may not change and will not change and should not change.
Thank you, sir.
Thank you, Isha.
Yeah. Here we are having excellent talks, but we see when we look at the hall, we see the MD chairs, we actually feel very bad. Maybe because of the last talk of the CME and all that, whatever people have their own reasons, but we don't feel nice seeing all these MD chairs.
Yeah, I think I'm sure that the perception about a conference will change and has to change in this country. Recently, I've been to Tanzania. Dr. Shripad, I can take 2 minutes more? I've been to Tanzania, and all the anesthesia postgraduates who are studying in India should feel blessed. The reason is, it was startling to know what at this point of time they have achieved. So out of the 120 anesthesiologists, 80 came to this camp. And you won't believe, of all the 80, not one of them have given a combined spinal epidural. Not even one. So they asked me to demonstrate combined spinal epidural for a patient undergoing a total knee replacement. So what I'm trying to tell, the amount of teaching that's happening in this country, the amount of workshops, master classes, conferences, deliberations which are happening in India is so good, and it's all available to the young anesthesiologist and even practicing anesthesiologist. Unfortunately, because it is available in plenty, we are not using it. We don't want to use it. And this is a very really sad state of affairs, and which they don't have to realize. Morning, when I was in Shema, I was addressing the undergraduates. I shared 2 stories. And one story was, which I definitely want to say, that why that African who does not know what regional anesthesia is, how much important he gives to learning regional anesthesia is an example. He was we do the World Federation of Society of Anesthesiologists fellowship in our hospital, 6 months program. So this happened a few years ago, and he's a very tall African. He came for 6 months program, and when one month was done, one morning, he was sitting in the preoperative room at 6:30 in the morning crying. He was supposed to come to the duty only at 8 o'clock. And I went to him and asked, Oboko, why are you sitting and what happened to you? When I went close to him, I saw his eyes moist and he was crying. And he said, my wife is dead. I said, what are you talking? When? Yesterday night. And what are you doing sitting here? He said, I don't have money to learn regional anesthesia. The World Federation gave me to and fro ticket. I have a written ticket. It's only 1 month into my program. 5 more months are there. I have not learned anything in regional so far. I came for a purpose, but I have not achieved my purpose. And now, anyhow, she is dead. She will not know whether I went to her cremation or not, but her mother is there to cremate her. So I will not go because I want to learn regional anesthesia. Where was he and where are our children? So the problem is possibly when it is available, they don't want to utilize. Or why is that when a big meeting happens with so many interesting talks are there? For example, the previous talk on septic shock spoke, Shivkumar gave all that is needed to look after a septic shock. And tomorrow, if somebody registered for the conference, decided not to be inside the hall, decided not to take the points, and he faces a patient with septic shock and he would not know what antibiotic to stop and what would be the kind of management that is given. The very purpose of a congress is to give the updates to all the students. And if the students fail to grasp all that is needed, I think it's really very unfortunate. Coming back to it, see Dr. Oboko, who was not even willing to go to the funeral of his wife because he thought learning is more important. And see that we do so much hard work to get best of the lectures and you will see the hall empty. That's a contrast, it's a paradox. And I think it's because it's available, we don't want to use it. Since it's not available there, he wants to give more importance. This is probably the conclusion I get it. But also, we made sure that we told our admin and our chairman, we gave money for him to go and attend the funeral and come back. We paid that extra for him because we told him, you may not, your wife may not know that you didn't attend the funeral, but you for your life will know that you didn't attend the funeral of your wife. But I wanted to quote this to say that several parts of the world has no teaching. India offers so much, and I'm very hopeful. I'm very confident that this would change, and India will come into the global race, and more people will take it from the meetings and conferences to decrease the perioperative morbidity and mortality. I think we'll be optimistic and we'll be very hopeful. So thank you very much, sir. Thank you. Thank you so much for your patient hearing. Thank you. Thanks for the opportunity. And I'm very happy to see that being conducted in such a beautiful hall, which itself shows the leadership involved in this organization thought that they should give the best to all the delegates attending the conference in terms of the infrastructure, the ambience, and the audiovisual. Thank you so much, Anand Bangera sir and Shripad sir. Thank you.
We now invite Dr. Sampatira Padmanabha, Dr. Abraham, and Dr. Shankar Narayan to present a memento to Dr. Shivakumar MC and Dr. Balavenkat Subramanian in appreciation of the excellent talk delivered. We sincerely thank our chairperson for steering this scientific session with such insight and precision. May I now invite Dr. Mahabala T.H., Senior Consultant Anesthesiologist and former HOD KVG Sulya, to present mementos as a gesture of our gratitude. As we conclude today's CME, we extend our heartfelt gratitude to all speakers, chairperson, delegates, organizers, and sponsors who made this event a success with their time, effort, and enthusiasm. We hope the sessions have been enriching and thought-provoking. We will now break for short tea break.